Hi guys, back with another session here. Let us understand a few more complications of common bile duct stones. We have something known as gallstone ileus, and we have something known as Myhre syndrome. Right now, and we should also understand there is something known as gallstone pancreatitis. Now let us understand what is gallstone ileus. In the gallstone ileus, we should understand. I've told you this is the gallbladder, right? This is the gallbladder. This is a cystic duct. This is an hepatic duct, and this is a common bile duct. If the gallstone is more than 3 centimeters, what does it do? This 3 centimeters adherent to the gallbladder wall, and it compresses the small intestine. Which part of the small intestine? Which is adherent near, that is duodenum. So it adherent, and this stone, okay, after once it adherence, it becomes a fistula. That means the stone passes from gallbladder to the duodenum. Once the stone passes from the gallbladder to the duodenum, the stone passes through the small intestine, duodenum, right? Ileum, right? Duodenum. This is jejunum, then ileum. And you can see this, the stone gets trapped at the narrowest part of the ileum. Right. Now, because of the trap, because of the stone which is trapped here, and you have got a triad. Right. So let us understand what exactly happens in the small gallstone ileus. We have got something known as a regular stride. Okay, okay, regular stride. In the regular stride, the first there is the fistula here. Do you understand, or do you agree? There's a fistula between the gallbladder and the duodenum. So the moment there is a fistula here, the stone passes here, the air from the small intestine, it enters into the gallbladder, and you can find an air in the gallbladder, that is pneumobilia. Right? Pneumobilia. And because of the obstruction here, remember, there is an intermittent and dynamic obstruction, because now patient can have a constipation on and off because there is obstruction here. It may relieve, the stone can move away from it, and the person can pass. And this is there's something known as trembling bowel obstruction. What do you mean by trembling bowel obstruction? Trembling bowel obstruction is the gallstone changes its position on different x-rays. Now say example, I took an x-ray now, right, and there is a position of the gallbladder at this location. Now what happens after some time, there can be a movement of the stone, and it can be present here. So there's not at exact point, there's a trembling bowel obstruction, right? That is a gallstone change position. And we should understand now where exactly what happens here is 2 feet proximal to the ileocecal junction. Okay, 2 feet proximal to the ileocecal junction. Now that is a point where you get a point 2 feet proximal. This is an ileocecal junction. This is the ileum. This is a cecum. So ileocecal junction, and this is a 2 feet proximal to the ileocecal junction. Now what I do, how do I operate this is important. The proximal to the stone, there's a longitudinal incision given at the anti-mesenteric border, and you take the stone out. So if you look into this here, you have an incision point, right? It is a proximal to the stone. You have a longitudinal incision, and this longitudinal incision is at the anti-mesenteric border, and you give an incision here, and what you do is you take out the stone, right? Hope you understand. Now let us look into the next important aspect, that is look for the multiple stone. That means there can be a multiple stones which can be passed from the gallbladder and the small intestine. So you're gonna milk it out, right? You're gonna look for the other stones also, so that there will be no recurrence, right? And the further aspect, you can avoid the operation. Now say example, patient has come, a patient is stable, the vitals are stable. Now what do you do is, Since the stone is coming from the gallbladder, I do a cholecystectomy. Good. And what you do is I close the fistula. I close the fistula. Fistula is a tract, right? I close the fistula. I do the cholecystectomy. I do the closure of the fistula at the same sitting. At the same sitting I do, right? The closure of fistula. If the patient, I do the same sitting. Now we should understand a signs of risk of perforation. What are the signs of risk of perforation? And no signs, so signs of ischemia. Now say example, there is a risk of perforation, right? And you have a signs of risk of perforation. And that time, in that aspect, there can ischemia. You can resect the point. Because of that, resection can happen. And after all, stone is milled back through the, and it is milled and back to the enterotomy, right? So 10% multiple stones can be drained. So remain of the small intestine shows you need to inspect it out, inspect it out. So I say example patient is unstable, you're not going to do all that. You're going to just remove the stone, enterotomy, right? You're going to remove that stone out. So that's the first. If you look into this is an X-ray which shows a gallstone. This is a pneumobilia. You can see a gallstone in the small bowel, and there is a bowel obstruction. The bowel obstruction, right? That's the best point. You should look into this, okay? And you have got something known as Merizis syndrome. If you observe carefully, this is the gallbladder. Now the stone. What happens to the stone? The stone blocks this hepatic duct. So you can have the other signs and symptoms of cholangitis, right? So Bizarre syndrome. It's a block of the hepatic duct. That is known as Merizis syndrome. Merizis syndrome. Now let us look into the next important aspect of gallstone pancreatitis. And what is this gallstone pancreatitis? What is that? So we should understand. You have got something known as a mild case. In the mild case, what happens in the mild case is important. In the mild case, you do a laparoscopic cholecystectomy in the same admission, right? Laparoscopic. You have got a mild case. You have got a laparoscopic cholecystectomy in the same admission. Okay. So example, now patient, what exactly happens here is the stone go and block at the I've told you that the common bile duct and the pancreatic duct, they open into the ampulla, the second part of the duodenum. Now because of the block at that aspect, the patient can have an inflammation of the pancreas. So gallstone pancreatitis. If a patient is it's a mild case, you do a laparoscopic cholecystectomy in the same admission. In the moderate to severe cases, the laparoscopic cholecystectomy is done in less than 6 weeks. So only in the mild cases, the patient comes with the mild symptoms. In such cases, you do the cholecystectomy on the same admission day. But the moderate and the severe, what you do is the laparoscopic cholecystectomy is less than 6 weeks. Now ERCP is done only when there is a suspected CBD stone. Remember, when you have features of cholangitis, you do a ERCP so that you can remove the stone out. ERCP is done only when there is a suspected CBD stone. Right, there is a suspected CBD stone. Right. In the next important aspect, in most cases, the gallstone pancreatitis, the pancreas is a self-limiting. That's a basic question they have asked. In the most cases, the gallstone pancreatitis is a self-limiting. Early ERCP, endoscope retrograde cholangiopancreatography, early ERCP removes stone, right? Early ERCP removes stone, decreases the morbidity of the episode of pancreatitis. They decrease the morbidity of the episode of pancreatitis. So early ERCP is better. They remove the stone, decrease the morbidity of the episode of pancreatitis. What is the next important aspect? The next important aspect is to purulent, right? To prevent the episodes, the further episodes of gallstone pancreatitis, what I do is a cholecystectomy is warranted. That is generally recommended during the same hospitalized. So, if a patient has a further to prevent the further episodes of gallbladder, that is the reason cholecystectomy is warranted, right? To prevent the further early ESCP, remove stone, decrease the morbidity of the episodes of pancreatitis, good, and I do a cholecystectomy. Then cholelithiasis, that is an intraoperative cholangiography should be performed. Remember, cholelithiasis. In cholelithiasis, intraoperative cholangiography, intraoperative cholangiography should be performed. That's the first thing we need to understand. Cholelithiasis, intraoperative cholangiography should be performed. What is cholelithiasis? It is a stone in the CBD. If a patient has a stone in the CBD, what you do is I do an intraoperative cholangiography. You put a dye and we'll show it. Okay, cholangiography should be performed, right? So let us finish the session by speaking about this pneumobilia. CECT shows pneumobilia. That is a fistula that permits a stone to pass into the duodenum and allows the duodenum allows the air enter into the biliary tree. So that's all you need to understand as of now. Thank you.